Hello to everybody. I am Stefano Meletti from Modena, Italy. I am the director of the neurology department at the University of Modena and Reggio Emilia, and the director of the epilepsy program. And it will be a pleasure for me to share with you some idea and concept about status epilepticus. I have no disclosure related to these topics. And in particular, I want to share with you some idea about key facts on status epilepticus diagnosis and definition, and also on which is the best way to diagnose and to have a monitoring of status epilepticus, of brain activity during status epilepticus by means of EEG recording and EEG monitoring. So, first of all, status epilepticus is one of the most frequent neurological emergencies, and after stroke is probably the most important neurological emergency. And around the world, each year, it is estimated that about 5 million of status episodes are recorded. And the incidence is quite variable in different parts of the world, and in North America and in Europe, we have an estimate of an incidence of about 30-35 persons for 100,000 adults a year. And we know that status epilepticus is more frequent in older adults with an age beyond 60 years, and in children from 0 to 5 years of age. And the mortality rate is quite high, and the pooled mortality ratios in adults are about 15-20%, but the mortality is more higher in the most severe cases of status epilepticus, in particular in the status epilepticus that we call as refractory or super refractory status, that in these cases the mortality is very high, around 30-40%. Importantly, while in children status epilepticus is often a complication, we can say, of an established epilepsy syndrome, in adults and in the elderly, status epilepticus is more often a condition that begins de novo. I mean, in a patient and in a brain that has no prior history of seizure or epilepsy, but is the consequence of an acute damage, of an acute insult to the brain. Now we have a practical mechanistic definition of status epilepticus that is focused on the time point in which we have to do a diagnosis and in which we have to start treatment with the objective to control seizure activity. And the actual definition says that status epilepticus is a condition resulting either from the failure of the mechanisms responsible for seizure termination or from the initiation of mechanism, which lead to abnormally prolonged seizure after a time point that is called T1. And it is a condition which can have long-term consequences after a time point T2. This means that time point T2 is particularly relevant because it's a time after which ongoing seizure activity can cause injury to neurons and to the brain. And in these cases, even if we at the end control seizure, it's probable that the patient will have a neuronal damage and neurological deficits due to prolonged seizure activity. And in practice, this means that for tonic-clonic status epilepticus, T1 is set at 5 minutes. This means that a tonic-clonic seizure that is prolonged over 5 minutes is status epilepticus, and we have to control tonic-clonic seizures within 30 minutes. And this means that seizures are not controlled within 30 minutes. It is possible that prolonged activity will injure the brain. For focal status epilepticus, that means status in which seizure activity is not generalized, but is focal in one hemisphere or in a more restricted region of the cerebral cortex. Time T1 was set at 10 minutes, and the temporal window in which we have to control seizure activity is extended to 60 minutes. So we have 1 hour of time to be able to control ongoing seizure activity. There are conditions with this time, T1, T2, are not already established because scientific evidence, in particular regarding the possibility for prolonged seizure activity to induce neural damage, are unknown. And this is particularly true for status epilepticus in idiopathic generalized epilepsy or in genetic generalized epilepsy. So a T2 threshold was not set already in the literature. Here you can view what can happen in the brain when prolonged seizure activity is not fast and rapidly controlled by drugs. And this is a picture that is a schematic picture of what happened in the brain. Continuous seizure activity induces a high metabolic demand, that is an increase in oxygen and glucose consumption. And this in turn causes hyperperfusion, which is a compensatory mechanism. We also have a disruption of the blood-brain barrier that can induce inflammation in brain tissue, and that is often something that is deleterious to the brain. And these phenomena cause at the end vasogenic edema. But the seizure activity is prolonged and is not controlled. We can shift from aerobic to anaerobic metabolism, lactate accumulation, and at the end to a situation in which edema is no more vasogenic, but is cytotoxic. And this can be a reversible damage, but in some instances can cause an irreversible neuronal damage. And we can now view these changes in the brain in vivo in man by use of brain MRI. And on the right, you can see in the case of a status epilepticus involving the frontal region, the frontomedial cortex in a young man, that seizure activity has induced a slight hyperintense change in signal in the medial frontal cortex. And in the majority of patients, these periictal MRI abnormality are reversible, and so they vanish when seizures are controlled. But in most severe cases, when seizures are prolonged for many hours or days, these changes can cause irreversible neuronal damage, and at the end, brain atrophy that could be focal or generalized throughout the brain. And here there is a brief schema of the therapeutic options that we have and of the definition of status epilepticus according to its response to the treatment, to the urgent and emergent treatment that we apply to the patient. We speak about early status epilepticus when we diagnose status, that is the first phases of status epilepticus, and in this first momentum, we use benzodiazepine to try to control ictal activity, seizures activity. If benzodiazepine fail to control seizures, we speak about established status epilepticus. And at this step, generally, we use anti-seizure medicine like phenytoin, valproic acid, or levetiracetam by intravenous formulation to try to control seizure activity. And if we fail, we speak about refractory status epilepticus. That is a status that is refractory to one benzodiazepine at least one anti-seizure medicine. And if the patient with refractory status has tonic-clonic convulsion, we need to rapidly use anesthetic agent like propofol or midazolam to try to stop seizure and to induce coma. And at the end, you can see if a patient at the weaning of anesthetic treatment restart with seizures with ictal activity, we speak about super-refractory status epilepticus. So the super-refractory status is the status that continues despite treatment with anesthetic for more than 24 hours. And this is the extreme and most severe condition in the continuum of status epilepticus. So as you can see, status epilepticus is an extremely evolving condition, is a complex condition because different etiology, different causes can induce in a brain status epilepticus. And we have different time window to try to stop seizures in the fastest way we can. Now move to diagnosis. Diagnosis of status epilepticus is can be in some instances done very simply by semiology. In case of convulsive seizure activity, of course, we don't need an EEG to establish a diagnosis of status epilepticus. But in the majority of the patients, and especially in cases in which motor manifestations are subtle or completely absent, and now we know that non-convulsive status represent at least 50% of the whole part of status epilepticus cases that we diagnose in clinical practice. We need the EEG as the gold standard technique that allow us to make a definite diagnosis of status epilepticus. And EEG is also fundamental also to monitor the patient during the evolvement of the condition and to monitor and guide treatment. Moreover, now we also have additional tools that are not gold standard but can guide treatment and also guide our management of the patient in status epilepticus. And first of all, I have already speak about MRI, magnetic resonance imaging is now a tool that is increasingly used during status, not only in the first phase to make a diagnosis, but to monitor eventual brain damage that is caused by ongoing seizure activity. And also, and probably in the next future, we'll have and we will use fluid biomarkers that track neuronal damage or neuronal inflammation to guide treatment, and also to have some measures that can tell us some prognostic information for what we can expect after the end of status epilepticus in each patient. And these concepts are true for every case of status epilepticus, but extremely important for the patients that are in the intensive care unit. So for all the patients in which we need to induce coma by means of anesthetic agent, the EEG is the fundamental tool that can serve to track what is happening in the brain of the patient and to guide eventually treatment changes during the evolution of status epilepticus. And here you can see an example of focal status epilepticus, a focal non-convulsive status epilepticus in a patient who has aphasia and hemianopia, and you can see ictal activity that is continuous in this 30-second page of EEG, and the ictal activity spike and wave have a frequency that exceeds the frequency of 2.5 Hertz. That is, we have more than 25 discharges in 10 seconds. And when we see a picture like this, we can, without any doubt, make a diagnosis of definite non-convulsive status epilepticus, according to the established criteria by the literature that we now are called Salzburg consensus criteria for the diagnosis of non-convulsive status epilepticus. And here you can see a scheme that shows you what we have to do in these cases. First, we have a clinical suspicion of status epilepticus or non-convulsive status epilepticus. We have to use EEG as soon as possible to make the diagnosis when we have the EEG criteria that defines that episode as status epilepticus, and to start promptly treatment. Treatment is by intravenous benzodiazepine, as I already showed you, or with anti-seizure medicine in the emergency department, in the neurology unit. And it's important to monitor both the clinical evolution of the condition and at the same time the EEG evolution. And only when we see a change of EEG and clinical response to anti-seizure medicine, to benzodiazepine, we can have a really very relevant information to say that we are doing the best for the patient, and seizures and are stopped, and the patient is regaining previous the neurological functions that were impaired by status epilepticus activity. In some cases, things are more complex, and we don't have EEG criteria that can say that that condition is without any doubt status epilepticus. One is the case of an EEG pattern that now is called lateralized periodic discharges, and this is an example in a young woman that presented with an hemianopia and aphasia again, and but in this case, ictal activity has not a frequency of 2 or 3 Hz, but is characterized by a very periodic and with a 0.51 Hz periodicity with this slow complex that we now call left lateralized periodic discharges, LPD. And this EEG pattern is part of what we now call as ictal-interictal continuum, but in some cases, and this is one good example, this activity is related to neuronal damage. You can see on the right an MRI that was acquired 24 hours after the beginning of the condition that show clearly an alteration in the temporoparietal cortex that are strictly related to the topographical distribution of the lateralized periodic discharges. So again, EEG and MRI are very relevant to monitor the evolution of the condition and also to track the appearance of brain damage or brain alteration. So to conclude, status epilepticus is a time-dependent neurological emergency. It is a common neurological emergency, and EEG monitoring remains the key diagnostic tool, the gold standard tool in the patient with status, both for the diagnosis and both for to have a monitoring and to track the evolution over time of the condition. And now it's very relevant to use a common language for the description of each pattern, and in particular for the diagnosis of non-convulsive status. And just now and for the future, an integrated multimodal approach that use imaging, fluid biomarker, EEG, and clinical funding is essential to assess the patient and to evaluate the patient for whom more aggressive treatment is needed to prevent neuronal damage. Thank you very much for your attention.